اتفضل دكتور هشام، نبدأ السيشن بإذن الله.
بسم الله الرحمن الرحيم. نبدأ السيشن كاردياك انجينج. First talk will be conducted by Dr. FARAH SHOKEIR under the title Major Aorto-Pulmonary Collateral in Pulmonary Stenosis with and without VSD CT angiography study. اتفضل يا دكتور.
Assalamu alaikum. You've probably heard about this a million times before, but let it be the 1,000,001, please. Okay, so how and why do MAPCAs form? In early fetus, the vascular plexus in the lung buds are connected to the segmental arteries arising from the dorsal aorta. By day 40, segmental arteries start to regress, and that is because the lungs become perfused by the RV and the sixth arch supply. By day 50, segmental arteries disappear, and the sixth arch develops into the central pulmonary arteries with PDA. So we're talking about the pulmonary stenosis with interventricular septum defect and pulmonary stenosis with intact interventricular septum. They look the same, but as a matter of fact, they're embryologically quite different. Pulmonary stenosis with VSD, the defect occurs early in the embryological life, where there's absent or suboptimal antegrade pulmonary flow. Segmental arteries of the aorta become so prominent and present as MAPCAs. Interventricular septum is not yet formed in this case. PSIVS in the interventricular septum is formed. MAPCAs have actually regressed to a certain extent. PS are well formed along with the PDA, so MAPCAs are quite rare in this case. We aim to study the behavior of the MAPCAs that develop in the PSIVS, compare them to the MAPCAs that develop in the PSVSD. Both types of pulmonary stenosis can actually occur at one or more of these levels, valvular, supravalvular, and valvular, as we know. So we aim to evaluate the effect of leveling of pulmonary stenosis on the number and diameter of MAPCAs developed. It's a retrospective study involving 75 patients in the period between April 2020 and April 2021. Two subgroups were involved, PSIVS and PSVSD. We leveled the cases according to the levels of the pulmonary stenosis into level 1, 2, and 3, evaluated the MAPCAs in each of them regarding the origin, type, number, and diameter. So we leveled the pulmonary stenosis into level 1, which means that any of these levels are involved, subvalvular, valvular, or supravalvular. Level 2, any of two of them are involved, and level 3, the three of them are involved. This is a sketch of how we leveled the pulmonary stenosis. It's just a drawing where red is involved and blue is not involved. This is level 1, this is level 2, and level 3 where the RVOT, the valvular apparatus, and the supravalvular apparatus are involved. So when we compared between the evolution of the MAPCAs in both groups, there was no significant difference between the number or the diameters or even the origin or the types of the MAPCAs. The levels of the pulmonary stenosis did not affect the average size or the number of the MAPCAs either. So let's review some cases. This is a level 1 supravalvular pulmonary stenosis with VSD. This large MAPCA arising from the dorsal aorta, it extensively branches into the mediastinum to give branches to the right and the left lung highly. Some of them course posterior to the trachea, to the bronchi, and others course anterior. And this is a large PDA as well. There is a large significant MAPCA arising from the left subclavian artery in this image. And these are the 3D images where the white arrows indicate the MAPCAs and the black arrow indicates the PDA. And this is the significant MAPCA that arises from the left subclavian artery. This is a level 2 valvular and subvalvular pulmonary stenosis with VSD. This is a large MAPCA or a bronchial artery that arises, prominent bronchial artery arising from the descending aorta, giving this significant MAPCA which branches in the mediastinum and supplies the right lung hilum. This is a corona reformatted images of this of this vessel, and this is the collateral artery. A level 3 subvalvular, valvular, and supravalvular pulmonary stenosis with VSD as well. In this case, there are prominent intercostal arteries which enhance the pulmonary supply via pulmonary pleural connections. There is also a branching MAPCA that arises from the dorsal aorta, and it branches extensively in the mediastinum. So in this case, there are hilar types and pleural types of MAPCAs. Lastly, this is a level 3 pulmonary stenosis, but this case is with intact interventricular septum. This case had a spectrum of hypoplegia on the right side, where there is tricuspid atresia, pulmonary atresia of the main pulmonary artery, and the hypoplastic right ventricle. This is the intact interventricular septum. There was an aneurysmal dilatation of the RCA with a fistulous connection to the hypoplastic RV. So, MAPCAs developed in PS-IVS and PS-VSD, after all, behave similarly despite their different embryological backgrounds and regardless of the level of pulmonary stenosis. The MAPCA's anatomical features are irrelevant to the sites and the levels of the pulmonary stenosis, as thereby classified by us. Levels of pulmonary stenosis do not relate to the severity of the pulmonary circulation affection, and last but not least, CT angiography remains an excellent method to demonstrate MAPCA's pulmonary anatomy and associated vascular anomalies. Thank you.
Thank you for this very nice presentation. Are there any questions for Dr. Farah? Okay, we will